Yeah.
Okay.
Do you want me to give this spiel really quick? Just
yes. Oh, please do.
Easy peasy. Okay, so quick upshot for people who are potentially just joining now / online people watching this video later. So we have a little bit of a lighter week this week. We're doing the antibacterial and antifungal stuff and antiviral stuff next week. This week and next week we'll be doing sort of a mix of the theme 3 content and a heavier focus on theme 2. So it's just a bit lighter overall and shorter. We will also, I think today, Carl mentioned we'll be going over some stuff for the CIP, the Comprehensive Integrated Puzzle. So stick around for that. We'll be giving you a little bit of advice there, and we'll open it up a little bit more as well. Make it a little bit more interactive, let you guys ask any questions that you might have. So massive thank you to all the people here live. We've had a lot of text problems. Fingers crossed it works now. Love you all.
All right, beautiful. Without further ado then, I'm not sure how Zoom recording works. So I'm not sure whether you can see my face or just what I'm screen sharing, but either way, hello, welcome to week 11 of PSPlatypus, and we're going to be going through these topics. And yeah, antimicrobials will be covered next week. All right, parasites. Okay, yeah, so they're organisms that benefit from a host and harm the host. So distinct from other organisms that might have a more mutualistic relationship, parasites, in gaining benefit from the host, actually actively cause some harm to the host. And you can classify them as whether they're inside or outside the host body. So endoparasites are parasites that live inside, and ecto are the ones that live outside. The important species that we've got here are all endoparasites, and we classify them into protozoa and helminths. There are other types of parasites. So for instance, viruses can be classified as obligate intracellular parasites. They have to be parasites in order for them to replicate, and they're intracellular, and they harm the host. But yeah, today we're going through these. I think someone is unmuted. So if you can mute, that'd be mute. All right, no rhyming intended. Protozoa. Okay, so protozoa are unicellular eukaryotes, and we're going to be going through these 4 species: so malaria, trichomonas, giardia, and toxoplasma. Yeah, without further ado, let's get into them. All right, so malaria is caused by 5 species. They're all Plasmodium species. So we've got Plasmodium falciparum. That's the one that causes most severe deaths. Most severe disease and the most deaths. And malaria is an infection of the blood and potentially also the central nervous system. The symptoms that you'll find are things like fever, chills, and sweating. And a key thing, I think there's an entire lecture that sort of revolves around, the malaria lecture entirely revolves around this concept that fever in a returned traveler is malaria until proven otherwise. Now, when we're talking about a returned traveler, we're probably talking about more sort of tropical or equatorial sort of areas, rather than if someone's traveled to Antarctica, it's unlikely that that's going to be malaria. But generally, fever in a returned traveler is malaria until proven otherwise. And that's because malaria has this possibility to cause such severe disease. So the way that we diagnose malaria, we take blood and then we do thick and thin blood smears on a slide, and we use a specific stain called Giemsa stain, and that will sort of show whether or not there's malaria present. Treatment, it varies. So I'm pretty sure the main ones that are recommended these days are chloroquine or hydroxychloroquine, according to British Medical Journal best practice. Although I'm not sure that was actually specifically in your lectures. The other 2 that we've seen in your lectures, so those are quinine, that causes ototoxicity, oto meaning ear, toxicity meaning causing harmful effects too. So ringing ears is an adverse effect of quinine. So obviously that has to be considered when you're prescribing this medication. And doxycycline has a pretty large amount of and sort of severe amount of adverse effects. So that's probably contraindicated a lot of the time. Okay, and in terms of prevention, so a lot of malaria management is around prevention. So there isn't a vaccine available, but there are other ways that we can prevent it. So by covering the skin with like clothes and diethyl toluamide, I think is what the abbreviated form of DET stands for. And that's basically insect repellent. So that's stopping the mosquitoes from biting you and sort of causing you to get infected with malaria. Nets as well for that preventing, and residual spraying, I think, to kill off mosquitoes, those vectors. And we'll be going into the life cycle just after this slide. And prophylaxis as well. You can take certain prophylactic medications that I think reduce the risk of you getting infected with malaria. Okay, so the life cycle of malaria. And this is something we're going to be coming back to. Not the specific life cycle of malaria, but the life cycles of parasites. They vary widely, they're quite complex. And so it's important to just acknowledge that the nature of parasites is that they have quite varied and complex life cycles. So specifically with malaria, so it's transmitted by a female Anopheles mosquito vector. So that's a specific species of mosquito that transmits malaria between humans and thus infects you. So you have different phases in a malaria, a plasmodium, protozoans lifespan. So they start as sporozoites that develop inside the mosquito's body. And then the mosquito bites the human or a human, and that results in sporozoites entering the bloodstream. They then actually travel to the liver, and then they replicate inside liver cells asexually. And eventually that results in the liver cells being so full of these maturing sporozoites that they actually rupture and merozoites are released. And then these merozoites are then they sort of spread to the blood more, and then they infect red blood cells, and then they develop into these things called trophozoites, which is a more mature form, and then further into things called schizonts, which themselves give on average about 16 merozoites, daughter sort of merozoites. So that's the way that it sort of augments and augments the number, increases the number of plasmodium protozoans through the body, resulting in more infection and more cells being infected and sort of causing all of those sorts of horrendous complications that you can get with malaria, and the damage to the blood and the central nervous system. Okay, so then, yeah, you have this, and that's still asexual. And then what you get is a sexual cycle of merozoites that produce gametocytes, which is a different sort than those trophozoites going into schizonts, which is to increase the number. The merozoites is to produce gametocytes, and then those, then a mosquito takes a blood meal. So it bites a human again, and it gets those gametocytes, and then those reproduce sexually and undergo meiosis, and that's how you get the sporozoites again. Anyway, that's specifically the life cycle of malaria, but as I was saying, it's pretty complex, but try and just go over it a couple of times and it'll make a bit more sense. Yeah. All right, let's go on to the next one. And I won't be going through complex life cycles for all of them. That was just malaria. So trichomoniasis is the disease, and Trichomonas vaginalis is the causative agent. So trichomoniasis is a sexually transmitted infection. It's a urogenital infection, so to do with the urinary system and the genital system, and that predominantly affects people with vaginas. Side point: not everyone with a vagina is a woman, and you don't have to have a vagina to be a woman. And it's mostly asymptomatic trichomoniasis in those with penises or people who are assigned male at birth. And so trichomoniasis can sort of develop to cause ulceration of the cervix. And the way that you find that ulceration is by doing a pap smear. So the key symptoms, one of them is smelly, frothy vaginal discharge, and that's sort of a buzzword for trichomoniasis. On top of that, abdominal discomfort, dysuria, which is pain on urination, and dyspanuria, I think that's the way you pronounce it, which is pain during penetrative sexual intercourse. Diagnosis, yeah, so the ways that you do that is either swab of the vaginal discharge, right, because that's where you'll be finding trichomonas, or yeah, a swab of the cervix, so pap smear or vaginal wet mount. Those can help you diagnose trichomoniasis. And treatment, as with all of these, it will vary, but the one that we've got here is metronidazole. Okay. So Giardia. So Giardia duodenalis is also known as Giardia lamblia, is also known as Giardia intestinalis. I have that in the notes section of this slide. So they're pretty synonymous. They are the same organism. They're just different names, synonyms. It's an infection of the gastrointestinal tract. Flagellated, which means it has flagella. So there's that sort of appendage that helps it move around. And it basically replicates in the small intestine. I'd imagine in the duodenum, considering the name. But what it'll do is it'll actually coat the gastrointestinal tract, and that will prevent nutrients from actually entering your enterocytes. So actually you absorbing nutrients. And so that can obviously have some pretty severe complications, you can imagine, if you're not actually able to absorb the nutrients that you're eating. So symptoms we've got here, a lot of sort of typical GIT symptoms. A key sort of buzzword again is greasy, foul-smelling stools. And greasy, sort of tying into the fact that also, like, you'll find these stools, they'll float on water because they'll have a high fat content. So that's another buzzword for Giardia this time. Diagnosis is by examining the stool. And treatment, those include metronidazole and tinidazole. And prevention, so you actually get this from contaminated water. So if you avoid the contaminated water, then, or if you sterilize the water, then that would obviously prevent giardiasis. Okay, toxoplasmosis. So that's an infection of the CNS and the lymph nodes. It's caused by Toxoplasma gondii. And sort of the main way that you'll see this is actually if someone has a pet cat, for instance, then there could be potentially their food has been contaminated. I don't know, they've put away the litter box and then they've not washed their hands properly and then they've gone and eaten something. And so that could actually cause toxoplasmosis. And basically Toxoplasma gondii, Toxoplasma gondii, invades the intestinal mucosa. It creates these, for 80%, more than 80% of people, toxoplasmosis is self-limiting and asymptomatic. But really where you'll find problems is with people who are immunocompromised. You can get these central nervous system complications. So sort of infections of the brain or lesions in the brain. And so diagnosis, and a lot of this, I'm just trying to touch on briefly. You probably don't need to know this in even this much depth, but yeah, through serology. So that's looking at your serum, so your blood, histology. So that's sort of the microscopy, and radiology. So that's imaging with radioactive elements as well. And then we've got different treatments. So pyrimethamine and sulfadiazine are the main treatments. This is a lot of me just sort of going through sort of dot points of different pathogens. So I understand it might be a bit hard to grasp. Just sort of come back to it a couple of times, try and quiz yourself on it, and that might help a bit. But luckily there aren't too many important species that we've been sort of taught. So helminths. Helminths are multicellular eukaryotes, and they're parasitic worms. So you can group them by shape, roundworm versus flatworm, and I've sort of got this tree here. And the nematodes are sort of what we're going to be going through, because those are sort of the ones that we've been told are the important species. But you've also got flatworms that you can talk about as well. Yeah, I'll go into them in more detail, but you can see sort of the flatworms we've got broken down into cestodes and trematodes, and then we've got the nematodes. All right, so hookworm. Hookworm is an infection of the small intestine, and ankylostoma duodenale and Nicata americanus are sort of the two main causative agents, two main nematodes that cause hookworm. The symptoms you'll get, actually in a lot of people, it's asymptomatic for the most part. And so for that reason, it can actually be pretty insidious, so pretty damaging, but over a subtle long term, because you're not actually realizing that there's a problem, but it is causing potentially, for instance, iron deficiency anemia. It's the most common cause globally of iron deficiency anemia. And yes, it's more a sign than a symptom, but I just wanted to standardize my symptoms table. Anyway, so what it'll actually do, and I think I've actually got a picture, the next slide, so I'll just quickly go to that, is the larvae will actually penetrate your skin, your bare feet, and then it'll travel up into your circulation, and it'll return to your lungs, and then it'll actually exit into your airways. You'll cough it up, and then you'll swallow it, and then it'll enter your gastrointestinal tract, and then you'll poo it out, and that's sort of what causes the cycle. So you can get itching of your skin because they've burrowed into your feet in the first place, and you can get a cough and a wheeze from actually it burrowing through your alveolar membrane out of your lung, like out of the blood circulation to your lungs into your airways. You can also get other gastrointestinal symptoms, so things like diarrhea, abdominal pain, malaise, so that's just general sense of discomfort with not much specificity, and fatigue, so that's tiredness or lack of energy. And a really big one that you'll find is iron deficiency. Yeah, because their teeth actually gripping onto your gastrointestinal tract can cause bleeding inside of your gastrointestinal tract, which means that you lose iron. Yeah, so yeah, diagnosis, so it varies, but you can do a stool exam, but that obviously won't show in your early infection because it won't have, traversed up through your circulation into your lungs, into your airway, down your gastrointestinal tract and out to your anus. Treatment is albendazole, and yeah, as I said, that's sort of the life cycle. Penetrates skin of feet, exits circulation in lungs, coughed up and swallowed, and migrates to small intestine. Okay. Filariasis. So that's an infection of the lymphatic system. And there are 4 different mosquito vector species that can transmit or be vectors for filariasis. Those are Anopheles, Culex, Aedes, and Mansonia. The symptoms, it's generally asymptomatic when the larvae are maturing. And then you can get lymphedema, which is swelling in the limbs caused by lymphatic blockage, so lymph is building up in the limbs, or eosinophilia, which is increased eosinophil presence in blood, which is, yeah, once again, a sign. But yeah, so the life cycle we've got is they enter via mosquito bite, they mature in your lymphatic system for around 5 years, so pretty long time. And during that time, probably not going to have many symptoms. Then they produce microfilariae into your lymph and your blood, and then a mosquito takes a blood meal of that. But so as the larvae are maturing in your lymphatics, eventually, they could cause a blockage that would result in sort of the swelling because the lymph can't drain from your limbs into your venous system. And then, yeah, mosquito takes blood meal and spreads. So diagnosis is something called a midnight smear, and treatment is doxycycline. Okay, enterobiasis. I think this is our last important species. So it's an infection of the skin and small intestine. And it's basically the sort of typical pinworm, threadworm you'll see it mainly infects and affects children between the ages of 5 to 10 years old because of their probably less than perfect hand hygiene. And it takes a fecal oral route. So you'll get the eggs will be laid outside the anus, and then there'll be scratching of the anus, and then transmission to the oral cavity, and then that sort of perpetuates the cycle. So the worms lie in the intestine, sort of and then the females migrate out of the anus at night to lay eggs outside of the anus to then transmit themselves around. This main symptom is an itchy anus, as you might guess. So there's a sellotape test, which is basically where you take a piece of sticky tape over the anus in the morning, and you take the tape off, and some of the eggs may have stuck to that, and you can do microscopy and confirm your diagnosis. And the treatment is mebendazole. All right. So those were our endoparasites. Those were like our key parasites. So now I'm just going to go briefly over some ectoparasites. So those are the ones that live outside the host body, and the 4 we're going to go through right now on this slide only are scabies, lice, ticks, and myiasis. So scabies, they live on skin, and they basically dig into your skin. They cause rashes, and you can get a secondary infection from them, likely due to your broken skin. Lice, probably familiar with head lice, also pubic lice. I'm not saying you're probably familiar with. Anyway, head lice, pretty common. You're probably relatively familiar with. They live in your hair. They take blood meals. Ticks, they also take blood meals. They can be dangerous. So they can actually cause something called tick paralysis, which I don't know too much about, and I don't think you need to either for this for the scope of this discussion. And myiasis is just when flies lay their babies in your skin, their larvae. All right, beautiful. Now it's time for me to take it away again with antimicrobial resistance and resistance transfer. Okay, so antimicrobial is also known as antibiotic resistance. This will make a bit more sense once you get the antibiotics, antimicrobials lecture next week from Deepak. So antimicrobial resistance is something that a microbe does. It's developing the ability to survive against an agent that used to be an effective treatment. So for instance, Staph aureus was perhaps at one point not resistant, or there are strains of Staph aureus that aren't resistant to methicillin or penicillin related antibiotics. But over time, over repeated exposure and some Staphylococcus aureus bacteria being resistant and then them not being killed off, they're then able to replicate, and then they're no longer able to be killed off. And so that sort of resistance becomes stronger and stronger. And actually progressively, it's a really big issue with nosocomial or hospital-acquired infections, because in a hospital, they'll be encountering a lot of different antibiotics. And if they develop resistance to more and more of them, then you have less therapeutic agents that you can actually, fewer therapeutic agents that you can actually use to target different microbes that cause disease. Okay, there are 5 main targets that antibiotics use to yeet or prevent the replication of or destroy microorganisms. So those are the synthesis of the cell wall, so the actual making of it, the making of proteins, making of nucleic acids, metabolic pathways, so involved in energy and things like that, and cell membrane function, so the maintenance and the continuous nature of the cell membrane. All right, so we can classify antibiotic resistance into 3 main classes, so innate, acquired, and non-genetic. So innate is just when an organism is naturally unable to be harmed by a specific antibiotic. So for instance, Mycobacterium tuberculosis, which causes tuberculosis, it has a mycolic acid wall around it, and penicillin actually can't pierce that. It can't get through it. So you can't treat tuberculosis with penicillin. So that's just innate resistance. Acquired resistance is when a bacterium or an organism was previously not resistant, but has developed resistance, and that can be through a few different ways. But the sorts of resistances you'll see with acquired resistance are things where, for instance, the microorganism will change the target site of the drug would attack. So now no longer does the drug actually successfully access or inhibit a certain target site that would normally mess with the microorganism. Yeah, so that's altering the target site, preventing access, or changing the uptake. So, for instance, maybe the microorganism has something called an efflux pump, so it can actually pump out the antibiotic as it's entering the bacterium. So that means that the antibiotic won't actually spend enough time inside the bacterium to cause damage. Or it could actually destroy or change, so antibiotic altering or antibiotic degrading enzymes inside the organism that actually change the antimicrobial agent, the antibiotic itself, resulting in, what am I saying? Resulting in it no longer being active, no longer being effective. And then we have non-genetic forms of resistance. So those are things like, for instance, you have an abscess in your body, and so you don't have, say, circulation or lymphatic drainage of that area. So there's actually no white blood cells getting to the abscess. And so you could have a little wall, a little container that has microbes inside it, pathogens inside it, that just aren't being detected by the body. So they can sort of plot and survive inside the body. Also dormant inside the tissue. So if a pathogen isn't being particularly active, for instance, tuberculosis, I think, has a dormant phase it might be liver, I might be wrong, but in a certain body tissue. And so while it's not causing much of a problem, the body might not actually detect and might not thus target and try to eradicate that pathogen. You can get things called biofilms, which is where what we've got here in this picture, which is actually, we've had I think a stent here in the heart or in some vasculature. And so organisms have actually grown on this foreign object that has been placed inside of a patient to actually help their artery, for instance, from being blocked. But as a result, because it's not actually human body tissue, it's a foreign body, say metal or plastic, that means that there's actually an increased ability for the microbes to actually persist on that foreign body. So that's what you get. It's called a biofilm. I think it might be Staph aureus on that biofilm. And then here we've got something called a protoplast, which is where actually the cell wall is degraded, for instance, by an antibiotic, but then the bacterium can still survive without its cell wall. It still sort of does its processes. It's just more in a sort of vague blob, and that's called a protoplast. All right, goodness, hope you're still with me. Okay, so there are three ways that you actually get transferred resistance. So that's sort of acquired resistance. Although acquired resistance can also just be through mutation. So transferred resistance. So there are three ways. There's transformation, which is where you're taking up a gene or a plasmid or something. You're taking up nucleic acids from an external environment. So say another bacterium has been destroyed, but then another competent bacterium can actually take in that and then integrate it into its genome or its plasmid, and thus it can actually make use of those genes. Conjugation is sort of what you might think of more generally. It's where sort of one bacterium and another, they have a sex pilus, it connects the two, and then they can actually transfer, so donate and receive a gene. Yeah, and transduction is where you have bacteriophage, which is a virus that infects bacteria, and it injects some gene into the bacterium. And that'd probably be more as a benefit for the bacteriophage, but that's another way that potentially, if for some reason there's a resistance gene inside the bacteriophage, the virus, then the bacterium can also make use of that. And so a lot of the time what you'll be seeing is that'll be going into plasmids. So that those are these small circular self-replicating double-stranded DNA sort of rings. And they're actually distinct from chromosomal DNA. So we can see here there's sort of a chromosomal DNA illustrated here, but then we've got the plasmid. So it's distinct from the main DNA in a bacterium. We have conjugation, virus X pluribus, that will actually transfer these plasmids between bacteria. And plasmids contain a bunch of genes, things that help them with replication, with being resistant. That's sort of the topic here. Virulent, so they're more infectious. I might be using that word wrong. Apologies if I am. Metabolic enzymes and conjugation factors. So conjugation, once again, being factors that actually help them create sex pili in the first place. Beautiful. All right, so we have risk factors for development of resistance. So these sort of tie in with the next slide as well, which is how to prevent antibiotic resistance development. But risk factors generally entail excessive, incorrect, or unnecessary use of antibiotics. So prescribing antibiotics for a viral infection, for instance, because the patient goes, oh, well, I want something to take, and the doctor goes, okay, well, I'll give you antibiotics because I know it's not going to cause you much harm. What it can do on a more systemic level is that if that's done over and over and over, you can get the development of, you're wiping out most of the bacteria except for the ones that are resistant, and then those can replicate. And so you're sort of selecting for antibiotic resistance. Yeah, so wrong dose. So the dosage is not high enough to actually kill off everything. Wrong duration, so you're not doing it long enough, or someone isn't taking the full course of antibiotics, and so that actually isn't killing off everything. Or general overuse or overprescription, as I was explaining. How to combat antibiotic resistance. This is pretty basic. So by avoiding the ways that we contribute to the development of resistance. It's basic, but it's very important. The antimicrobial creed we've got here is Mind Me. So microbiology guides therapy wherever possible. Indications. So if we're deciding to use a specific antibiotic for a specific infection, that should be based on studies and trials that have been done to prove that this is effective. Narrow spectrum, so we don't want something that's broad spectrum if we can avoid it, because if it's broad spectrum, then that will be killing off way more than we need to, which will cause, other problems generally, like diarrhea and things like that if you're killing off the gut microbiome. But on top of that, you'll be killing off, you'll be targeting more bacteria than is necessary, and that can actually result in, the development of resistance. Dosage appropriate to site and type of infection, pretty self-explanatory. Minimizing duration of therapy. So obviously you want to do it for as long as is necessary to properly treat the infection, but you don't want to be doing it for longer than that, because that's going to be increasing the bacteria's exposure to antibiotics, which increases the likelihood that some bacteria develop resistance or happen to have resistance. And it's that sort of selection for the antimicrobial resistance, and ensure monotherapy in most cases. So that's using one antibiotic rather than many, but that's obviously in most cases, not all. All right, prevention and change. Shall I change the screen share or?
Yep, that'd be good.
Beautiful. All right, let's see screen sharing.
Alrighty, so let me put up. Can you guys see the slides?
I can see the slides. I think we've got one question about.
Yeah, so Darren's asked, why is becoming a protoplast not innate resistance? So my understanding is that I think it's still something that has to be like developed rather than something that is, or I'll have a quick Google and get back to you actually. Deepak, you take it away, and then I'll
Yep.
past thing. But also it's something that is very, very briefly touched on. So not too much to worry about. But yeah, I'll give it a quick Google.
All right, so it's going to be medicine of the mind. So I'm going to talk about prevention and change in the context of changing behaviors, health behaviors, because we know that when we improve health behaviors, we improve health outcomes. So there are a lot of different models that we're going to talk about to understand change in health behavior. So an example, for example, is this thing. So we're going to talk about this one first, and it's called the Health Action Process Approach, or HAPA for short. It has two different stages. One is the motivational stage and one is the volitional stage. And the motivational stage is to do with the person actually wanting to change their health or change the behavior, while the volitional stage is more about actually planning the behavior and planning how to do that and other things surrounding that. So first we see, if you just orient yourself to this diagram, it's kind of like a left to right kind of thing. So if you start on the left, where in the motivational stage, you're trying to form the intention for that behavior. And there's a bunch of different things that influence that. So we have task self-efficacy. So that is your self-evaluation of how well you can do that task. Outcome expectancies. So what you expect to occur because of that behavior. So that would be the benefits of that behavior. And risk perception, meaning the risk of continuing your past behavior without changing. So yeah, and they all feed into the intention to change. Task self-efficacy kind of overlaps with action planning. So we know that if you have enough self-efficacy, that is going to positively impact your, or just affect the way you plan out the behavior. The second stage is volitional. So to do more with practical planning. So we have coping self-efficacy. So what that means is coping with essentially roadblocks or changes that occur that might need to change the way you approach your behavior. We're going to go through some examples in a second, but just moving on. And after you have your coping planning and your action planning, it moves into the actual action itself in the red. And it has a circular sort of thing where you take initiative to do that behavior, you either maintain it for the rest of your life or you eventually relapse and you recover, and then you start again with the initiative to continue that behavior, as is pretty typical in a lot of health behavior changes. And in this part, what's important is recovery self-efficacy. So that is your self-perception of how well you can recover after you relapse, so after you stop that behavior. So some examples. So for example, coping would be the fact that you can persist even if you don't see any changes. Action planning would be specifically planning out your actions, where, when, and how, using SMART goals. Coping planning would be, again, if something goes wrong, like if it's raining, then I can just do something else that is in the same vein, but sort of replaces it. Recovery, so for example, I can cope if I get sore, and that is that. So we just talked about a model for behavior change. Now I'm going to talk about another one. So this is called the trans-theoretical model of change, or usually called the Prochaska-Di cycle, because there's, I imagine, other researchers who came up with this. So I want you to start at the top here. So there's the pre-contemplation stage, where the person whose behavior we will kind of want to change is in a stage where they don't even recognize the need for change and they're not actively considering the change. So this is typically where most people would be before they want to think about change. And at this stage, once you sort of talk to them about the possible change in behavior and how that might benefit them, then they can they can move on to the contemplation stage where they recognize the problem and they're considering change. And then through all of these mechanisms, once they understand that this is a change that they're motivated to do and they're willing to take action, we enter the action stage. So they've initiated the change. And again, you just kind of see this circular loop of initiative, maintenance, and recovery. So we have maintenance, so you're adjusting to the change and practicing the new skills of behavior. You sustain it and you abandon the risky behavior, or you relapse and then it goes down the cycle again. There's a bunch of criticisms for all of these models, really. Limitations being, they're models, they might not actually reflect reality. But specifically for this one, there's a blurry line between the stages. Stages can be of varying durations, and there's limited individual variation in this model. So it doesn't account for a lot of the way that people actually work. Alrighty. So when it comes to changing behavior, that can also be directly linked to changing attitudes, because attitudes inform behavior. And when we think about what an attitude is, this is a definition that you're going to be given, or we were given in our lecture. So it's a relatively enduring organization of beliefs, facts, and behavioral tendencies towards people, issues, or objects. And I think the key there is that it's relatively enduring. So it's going to last for what could be a lifetime. And there's a bunch of different components to attitudes. So we have the cognition. So that's your cognitive beliefs, thoughts, and ideas about a topic. Your affect, so your emotional response to a topic. And your behavioral tendencies, so your predisposition to behave in a certain way relative to a scenario or topic or object. And there's this idea of cognitive dissonance. And what that essentially is when there's a discrepancy between two different attitudes that you have, or an attitude and a behavior. And what we need to do to solve that dissonance is to either change one attitude or change one of the behaviors. All right, so we just talked about components to attitudes. We can also think about attitudes as having different dimensions. So for example, there's the strength of the attitude, its impact and durability, the importance that you personally appraise for it to have in your life, accessibility. So if the attitude is easily activated, meaning it's very actionable and specific. Complexity, again, it's kind of related to the specificity of it. So it's either very general or very specific. Implicit versus explicit. So that is, I think, it's like unconscious attitudes versus explicitly thought out attitudes. Ambivalence, so that's the emotional aspect of it. I think kind of related to the affect, so that component of the attitude. Coherence, so that's internal consistency, so it not clashing with other attitudes and it not creating cognitive dissonance. And you can kind of use these dimensions to understand when attitudes are going to predict behavior. So attitudes are specific to behavior. I mean, if attitude is specific to behavior, then it has a greater chance of predicting it. So that's accessibility. If it's unconscious, if it's strong, and if it's developed from personal experience. So I think it's talking about importance here, which is personal appraisal. And also if the attitude is appraised as a societal norm and in the environment, and other significant others also have the same attitude. So if we want to change the behavior, we might need to change the attitude, which means we might need to persuade them. So when we talk about persuasion, it's just an attempt to change an attitude held by another person. And a persuasion is composed of two people interacting with each other and a message is sent across. So we break it up into three different parts. So there's the source of the message, there's the message, and then there's the audience. And a lot of different factors in each of these categories can impact how the transaction occurs. So the source, so the person who sends it. So there's a bunch of different things that can influence if the audience is receptive. So if they're credible, if the source is credible, trustworthy, and likable, that is very important. As for the message, there's three key parts to the message that is that we need to think about. So there's what. So what is the message? So what actually is a key message? And then after that is so what. So what are the actual benefits and the needs for change? So, and there's the now what. So that's the defined desirable actions that need to take place in the present that the message is talking about. A compelling message also has some other characteristics. So for example, it should be a two-sided argument. So meaning it balances out pros and cons instead of one-sided, and that increases credibility. It should arouse a bit of fear, but too much would cause avoidance, so it needs to be used sparingly. Repetition is important, especially of the key messages. And there should be an emphasis on efficacy and the audience's ability to change. And we can see that in different forms of motivational interviewing. And as for the audience, this person receiving the message, and the efficacy varies on a bunch of stuff, varies very individually. So there's a lot of demographic stuff like age, gender, the attention, if they've been paying attention, prior beliefs. And prior beliefs is actually something that's very important because there's something called the disconfirmation bias. So you might have heard of the confirmation bias when we pick up things that agree with our worldview, but disconfirmation is to disregard things that contradict our worldview or prior beliefs. So when we appeal or when we try and persuade people, there are two different routes we can go. There's the central route and the peripheral route. And this is part of the elaboration likelihood model. What the elaboration likelihood model essentially is that it's just the likelihood that we should elaborate for our message to get across in the most effective manner. Or that's an easy way to remember it as well as think about it. So there's a central route, which is the appeal to reason. So this is when a motivated audience actually pays attention and thinks about the argument, and this leads to enduring change. So note the fact that attention is, again, an important thing, as we identified here as well. And there's the peripheral route, which is an appeal to emotion. So we have an unmotivated audience who does not pay attention. And in this case, the likelihood that we should use elaboration is pretty low. And this involves low elaboration, surface level discussion, and typically doesn't lead to as much enduring change as the central route. But it's useful in its own scenario. And that is my part, I believe.
Back to me.
Nice.
Wonderful. All right. So now we're going to go through some spirituality and environment, telomeres, all the good stuff. Yeah, so spirituality and environment. So spirituality is exploring meaning in life. And it's not the same as religion or religiosity. But one of the main ways that you can be spiritual is through religion, or one of the most common ways. But also you can explore spirituality, explore meaning through philosophy, altruism, so that's doing good for others without any aim for benefit to yourself, just being creative and enjoying the environment. A key statistic is that 83% of patients wanted doctors to ask about their spiritual beliefs, specifically in the context of life-threatening illnesses and the conditions of loss of loved ones. So do you consider yourself to be a spiritual person? And discussions about things like, why is this happening to me? And things like that. And then we have two different types of well-being. So hedonic well-being being sort of the search for instant gratification. So it's pleasure seeking, sex, gaming, eating, all of the fun stuff. I don't know. Anyway, but that can actually specifically lead to increased inflammation, which is generally a bad thing when it's not responding to a specific stimulus, compared to eudaimonic well-being, which is where we are gaining well-being from sort of spirituality, that pleasure from finding meaning and becoming or sort of achieving your goals, becoming the person you want to be, sort of stuff. And that can lead actually to improved immunity, which is a good thing. It's pretty straightforward in that sort of sense. Okay, when we're talking about religion, we can talk about religious orientation. So that's sort of the reason that someone is religious, the reason that they are, and sort of the which way they're looking in their aims of being religious. So intrinsic religious orientation, that's adhering to the values of the religion because of sort of a sincere, genuine belief. But it's also, yeah, sort of intrinsically with integrity, adhering to those values because you believe them to be beneficial and you believe in the religious edicts. And that can sort of lead to positive religious coping, which can result in things like fewer depressive symptoms and actually improved clinical recovery. So intrinsic, so sort of a genuine, sincere interfacing with religion can be beneficial. But if you are being religious because it's sort of a social pressure and it's a means to self-serving ends, so it's to sort of look like a good person, to get along with those around you, and it's sort of that superficial function, then actually that can result in negative religious coping because it's not something that's actually causing these sorts of benefits of actually genuinely believing. You sort of almost not necessarily faking it, but I think it's relatively clear that it isn't as genuine and sincere as intrinsic religious orientation, and that can lead to poorer mental health. So generally, religion has been shown to be protective against things like depression, suicide, not so much suicidal ideation, but more suicide attempts and potentially actual death by suicide. Substance abuse, so it reduces the likelihood that you're going to abuse substances. Physical illness, and these are probably a lot of these are sorts of correlations, I'm not too sure, but physical illness, so reduced rates of cancer, cardiovascular disease, and longevity mortality rates. So on average, people who are religious live a bit longer. Also, very important, longer telomeres, improved mood, and a decreased likelihood of crime in adolescence, probably because of that sort of community aspect of religion. I'm not very qualified to talk about this. I'm not religious, but these are the main teachings that we've been given in our HEP lectures. All right, on to environment. So there are three types of environment. We've got physical, human-made, and non-physical. So physical just being nature, the natural world, ecological sort of surroundings. Human-made are what it sounds like, things that we've built. So the house that I'm sitting, the room that I'm sitting in, the house that I'm sitting in, things like that. And non-physical, so things like your domestic environment. So how is your home life? Your social environment, how, like, what is it like? The people who, what are the people who are around you like? How do they impact you? How do they surround you? Cultural environment, intellectual environment. You can sort of nut it out. You can think it out. There are different health effects that result from your environment. So directly, you can sort of think, well, if the air quality is really bad, that's obviously going to have some pretty obvious direct impacts on your health. Same with things like if you're exposed to noxious chemicals. If the soil quality is really bad, then that's going to change the quality of your food, or potentially if it's like radioactive, then that's just going to be affecting you by the radiation, potentially increasing rates of cancer, and climate. So, for instance, in hotter climates, I think there are increased rates of cardiovascular disease and things because I think you have to have. I'm not too sure, but I'm pretty sure it can result in certain diseases that are more common in, for instance, tropical, equatorial sort of climates, just because of the temperature or the humidity. Indirect health effects, on the other hand, so those are things that sort of the environment impacts something that then impacts your health. So it creates another thing or causes another thing that impacts you rather than directly affecting your health. So for instance, if there's a poor environment, then that could lead you to have worse mental health. Indirect other aspects like disease vectors. So for instance, mosquitoes, once again, in those sorts of tropical climates, community, economics opportunity. There are a bunch of things that can sort of change your, if you're of lower socioeconomic status, then that can result in a bunch of things that can lower your overall health or cause other things that can be an active detriment to your health. And the climate can also sort of cause those other things. So for instance, with disease vectors being more common in hotter, more humid climates, specifically mosquito vectors. Okay, and some brief statistics. So a quarter of all global disease is due to modifiable environmental factors. So obviously pretty important. And obviously prevention is a lot cheaper than primary, secondary, or tertiary treatment. So better to get in there early. A third of all disease in children is due to modifiable environmental factors. So that's even more is in children. And just as one example, a third of Australians are actually now vitamin D deficient, I imagine, due to sunscreen and being indoors. But it's quite interesting because that's contrary to the fact that you get a lot of sun in Australia. All right. And these are some slightly less important, but still worth knowing more holistically concepts. So you have Barry Commoner's 4 laws of ecology. So these laws sort of enable you to reason more about the way that environmental changes will affect, or the way that environmental changes will affect the rest of the environment and things like that. So everything is connected to everything else. So the point being that you will get an environmental change in one area may result in runoff that goes to the ocean that then can change an entirely different area that has various effects. So, sorry, I'm being quite vague, but these laws are supposed to be sort of all-encompassing, so it's hard to discuss. Everything must go somewhere. So waste products, for instance, that we produce has to go somewhere. Plastic in the ocean, landfills, things like that. Think about the fact that anything that you produce, nuclear waste from, I don't know, weapons manufacturing or energy production, it has to go somewhere. You can't just, there's no such place as just, that is completely unconnected from where we are. There will sort of be run-on effects. Nature knows best. So this isn't sort of some, wishy-washy concept. It's more that any change, any man-made change will probably be at the detriment to the natural environment. And that's pretty evident in things like fossil fuels use for energy production. And that sort of ties into the fourth one, which is sort of a culmination of the other three. There's no such thing as a free lunch. So everything must go somewhere, but also everything must come from somewhere. Anything that we do or use will have environmental, ecological repercussions, consequences as a result. So those really should be considered, and we should be considering how to counterbalance them so that, the world doesn't explode as it sort of currently is. Triple bottom line is just another brief concept. So it's decision-making, a decision-making process where we consider environmental, social, and economic factors, because those are all actually quite inextricably tied. Ecological footprint is another concept. Your carbon footprint is sort of a similar concept. So ecological footprint is the amount of land and water that is needed on a continuous basis to make all of the resources that are being consumed and get rid of all of the waste products that are resulting from that. So that could be, in the context of an individual person, in the context of an individual product. So for instance, an apple or a piece of meat, or an iPhone. Or it could be in the context of an entire business or an entire population. Yeah, that's pretty much it. Thank you. And sorry for the wishy-washy sort of aspect. All right.
All right, so we're going to go on to health and human rights real quick. Okay, I should be able to see that. So this is a pretty self-contained little topic. It's mostly going to be explored through the case studies, and so the actual application of the concepts to certain examples that you'll be given through your tutes and through the actual questions. But we'll have a look at some of the theory here. Okay, so when we talk about human rights, typically we're talking about either international law or domestic law. So the sort of foundation of human rights in terms of our modern understanding, the contemporary understanding of human rights, is the Universal Declaration of Human Rights, which was formalized in 1948. And that sort of came out of World War II. Obviously, the Holocaust and other atrocities happened during the conflict. And then we decided, hey, we should have some sort of codified set of rules on how to treat people, basically. And so that's the major founding document, and that's also still the major international definition of human rights. We can have other more localized and more elaborate, in some cases, versions of human rights. So Victoria has a Charter of Human Rights. And so those are also relevant when we're talking about clinical practice. So we have two types of rights. So the first type is the easier type to enforce. So that's civil or political rights. So if I say you have the right to free speech, for example, all I need to do to enforce that right is to prevent the government from encroaching on free speech, basically. And so because it's an inherently sort of legalistic right, it's pretty easy for me to enforce it. Now, on the other hand, we also have rights which are economic, social, or cultural. So the right to life, basically. So that can be both a civil and political right in the sense that the government isn't allowed to just kill people, and it can also be a economic, social, or cultural right in the sense that we need to provide sustenance. We need to provide the basic requirements of life to people in order to fulfill that life. So the right to health falls under both of these categories as well. And so we need to be aware that the second part requires some sort of active investment. So it's not enough to just say you have the right to health, you need to actually provide that to people. So the World Health Organization is a UN body, which is also responsible for sort of ensuring these rights, especially the right to health across the world. And that's also where we get the holistic definition of health. So a complete state of physical, mental, and social well-being, as opposed to just the absence of illness. I talked about how the right to health sort of falls under both categories. So the first one is the right to bodily autonomy and freedom from interference. So that's the sort of civil political side of it. So basically, you have the right to control what goes on in your own body, and you have the right to be protected, or you have the nobody has the right to interfere with your body without your consent. And on the other hand, we also have a more aspirational side to the right, which is that you should have a functional and equitable health system. And so beyond that, to sort of expand on that a little bit, we should also have an effective health system. So we looked at access to healthcare a few weeks ago, and it's the same basic concept. So the idea that just because there is a health system doesn't mean it's a working health system. And so there's always a gap between the theoretical capacity of the health system and who actually gets treated. And we need to try and minimize that as much as possible. So that's a dimension of this right. Okay, so one of the most important things we get in terms of practical applications out of the right to health is the principle of medical neutrality. So it basically means, no matter what your patient is and no matter what your identity is as a medical practitioner, your job is to provide the best standard of care to them. There is there's no caveat there. So the identity of the patient should never, ever affect your clinical practice. And so this is really important, as it says there in the dot point, because that's how we have a high level of trust in the medical profession. The reason that doctors and health professionals in general consistently have a high level of trust among the general population is not just out of nowhere. It's because we hold ourselves to this standard, and so it's incredibly important that we will continue to do so, because if we don't hold ourselves to that, then we lose trust. And of course, when we're talking about health issues, because people have the right to bodily autonomy, because they have the right to choose what happens to them, it is incredibly important that people trust us. And you wouldn't trust someone who you can't trust to have your best interests at heart. So we can't ask patients to do the same. So we remember that the principle of medical neutrality is key. And so when I was talking about the sort of applications and sort of specific examples, we're sort of looking at vulnerable populations. So who are the people for whom the right to health may be significantly harder to get because of various barriers. So incarcerated people. So there's some inherent risk there, both in like the fact that they're in prison, which is not necessarily the best health environment, and also because there may be legal and bureaucratic barriers to getting them care. People in conflict zones and areas with limited rule of law, so especially in the developing world, this is a major issue. And so often we get trampling of human rights in those cases. And we've also got people who are just vulnerable in general. So children and people with disabilities, there are risks to their human rights, even in more supportive areas and more supportive societies like Australia, but especially in conditions where we have an overall danger of human rights or health to the population. So again, conflict zones, limited rule of law, things like that. These people are especially at risk because they have much lower ability to advocate for themselves. And if they haven't changed the example, then one of your things you'll be looking at in regards to health and human rights is actually child brides. So girls who are forced to marry at a very young age and often have children at a very young age. So these people have no recourse, right? They can't advocate for themselves, they can't defend themselves, they aren't able to leave. And so that becomes, in very real terms, a health problem. Both for the mental health of these people, the psychological health, and also for things like child pregnancy, basically. So you can see how if we let people's human rights get trampled, we almost inevitably end up having flow-on consequences for their health. And so these are sort of inherently intertwined concepts, which we can't really separate. All right. I think that brings us to the CIP thing, which is the last thing we wanted to cover. And so this one's
beautiful.
a little bit more freeform.
You've chucked a slide in there.
I have.
I see.
Ninja.
Yeah. That was not there earlier. Okay, so I mean, I think the question was basically like, what is the CIP, etc. So the comprehensive integrated puzzle is basically a table that has, on the horizontal axis, it'll have a bunch of conditions. And then on the vertical axis, it will have different topic areas. So for instance, I'm just getting up one right now. It'll have medical history, physical examination, investigations. So you sort of classic clinical skills sort of aspects. And then it'll have pharmacology, anatomy, physiology, management, health, or things like that, microbiology. So the idea is that it's sort of testing your breadth and depth of, or more so your breadth of knowledge on a variety of conditions. What it'll do is it will present you with, so it'll go through by topic by topic. So yeah, here's a good one. So this is an example for, and I'm pretty sure usually you're told what system you'll be quizzed on. So basically you'll be given, for instance, 1, 2, 3, 4, 5, 6, 7, 8, 9. You'll be given 9 histories, and then you'll have to match the history that you've been given to, oh, this one seems like it's for an AMI, a heart attack. This one seems like it's for pericarditis. This one seems like it's for AFib. Now, this is an example. The conditions that you'll be tested on will be ones that you've been exposed to in some contexts, so don't worry about that. You're not expected to know cardiovascular pathologies. But yeah, it'll be presented, it'll be in the form of a Moodle quiz. You should, as far as I can tell, be given a formative one first, so that you get a brief understanding of what the heck is going on. And then you'll eventually be given a summative one. But the general idea is that you'll have a page of a Moodle quiz will be, for instance, section 1, medical history. It'll have however many histories. and then you go, okay, well, this history, which is which A is the first history, A matches with, oh, this condition. And the good thing about that as well is that you're eliminating. So once you've allocated that history to a specific condition, you can't put it for multiple. So you'll be able to go like, okay, well, this one is a heart attack. Okay, well, now I only have 8 options left to deal with. So you can sort of logic out a few of them, and a lot of the time it'll come to, okay, well, there's this one and this one. I'm not really familiar with these conditions. I'm not really familiar with these histories. Okay, it's a bit of a coin toss, but there's a 50% chance that you'll get both of them right or both of them wrong. And you sort of go through all of that for each of the sections. So for instance, it'll have some statement about pharmacology. Oh, this drug is used, or this drug is contraindicated in this condition, or things like that. And then you'll go, okay, well, that's obviously this condition. That's obviously this one. Oh, this isn't obviously that one, but I think it's this one. And because I've eliminated the other ones, oh, it has to be. And then in terms of marking, basically, if you get, I think it's 0 to 59%, correct? You get no marks. If you get 60 to 79%, then it is half marks. And if you get 80+%, then you get full marks. So that's just in terms of if you get, and the way that that's marked is basically each correct placement of a puzzle piece. So this history goes here for this condition. That counts as sort of a mark. And so there's, sorry, as a sort of a point, and then all of those, and then divided by how many boxes there are. So here we've got 8 sections by 9. So that's what, 72. I think, 72 potential marks. So yeah, then you convert that into a percentage and use those percentage breakdowns to get no, half, or full marks, which is good. It means that if you're generally familiar, but you get a few wrong, you still get full marks. But that being said, I don't think the CIP is a super, like, I don't think it contributes massively to your marks, but it is a very good way to sort of comprehensively check that you're able to integrate knowledge in a puzzle form, hence the name. That's basically it. Is there anything that you want to add, James or Deepak, or are there any other questions that people have?
I didn't have anything much to add. I can't remember if we had one in semester 1. I don't think we did. So I don't know.
Yeah, I'm not sure what conditions you'll be quizzed on.
Yeah.
But I'm presuming I think you're going to be given a formative one sometime soon. You have a Q&A 5 till 6 p.m. tonight.
Yeah.
So
you'll find out more there.
hopefully, yeah, you should be able to get some more official information. Yeah. But
so
then, yeah, you can see, yeah. Go ahead, James.
It'll work like this. So you'll basically, you should be on Moodle, I think, for you guys as well. I don't think they'll change that. So it'll be like, basically they give you on a bunch of pages, each page will be devoted to one of those sections. So like section 1, section 2, and then you'll have, like Kyle said, a bunch of medical histories, and then you just match them. And like you said, I think that's probably one of the things worth stressing. Like there is a lot of value in the fact that you can eliminate stuff. So definitely, like, the strategy with this is to go for the stuff that you like understand and are confident in first, because like you're better off doing that, and then at the end you're left with like 2 that you don't know, and oh well, okay, well this can only go with that one now because they're too different from each other, as opposed to trying to puzzle over something that you don't really understand for 20 minutes, and then rushing through the rest of them.
I mean, and that's the other thing. I think CIPs, they aren't super time pressured. Thankfully, much like basically all of med exams, aside from, I guess, OSCEs when in person and proper. But I'm pretty sure you have an hour to do the CIP. So yeah, it means you can't spend too much time dilly-dallying. What a fun phrase. Yeah. Anyway, yeah.
So yeah,
anything
so like,
else?
Yeah, it will be different all the time. I'd say in general, probably don't expect to just do it all chronologically. Again, sort of like the same idea, like doing the stuff that you know first. Like feel free mentally to just go through, do the stuff you know, and then go through again and try and slowly nut it out. Again, you're better off like banking the stuff that you know, because that will make it easier to get the stuff that you don't know super well. But hey, you guys are pretty amazing. For all I know, you guys will just go all the way
sticking
through.
around. Yeah.
Yeah. All right.
Wait, one more thing I wanted to add is that don't forget that a lot of the stuff is more recognition rather than recall. So if you're like going through revising stuff, don't get too like stressed about, oh, I need to memorize, or like I need to remember this stuff. It's if you can like understand, for example, in this table, like I know that atrial fibrillation is different to like ventricular fibrillation. And if I roughly know like how to identify between them, so it's more like differences between things to help you recognize rather than recall. But
That's a great point.
I think you guys should be good.
Yeah, don't go rote learning any descriptions, because they'll like, it's all stuff that are right specifically for the CIP. Med still tends to be like pretty typical presentations. So like if there are certain telltale symptoms or whatnot for a condition, they'll usually put them in. So they won't make it too hard for you, but they also won't stick to like a pre-run script. So definitely, again, like understand what you're looking for rather than just like memorizing there are these 5 things and it will only be these 5 things and it will always be all of these 5 things.
Yep.
Lovely. Were there any other questions that we wanted to capture in the recording? Otherwise, I'll probably turn the recording off. Anything people wanted to know? If not, I'll probably thank everyone for watching. Thank you for watching asynchronously.
Yes, thank you.
Thanks
for tuning into the YouTube. And as always, shoot us any messages, any questions you have. We're happy to help.
Yes, and also and little addendum with that. If you again want anything specific in regards to exam revision, that sort of thing, feel free to check that. Sahil has put up a really amazing practice exam on the group, so please feel free to do that. Have a go at it, see how you go, and use that to guide your revision, hopefully. But yeah, so like messages if there's anything specific you'd like to see. Ultimately, this is for you guys, and let us know what you want us to do with it.